John Ellis. So the innovation we're focusing on today is your work on cataract surgery. What do the waiting times and waiting lists look like at the moment then?
It is hard to describe a more broken system. Someone said, I think I'm correct, that 1 in 9 people in the UK is on a waiting list for something. I mean, hernia repairs, hip repairs, or cataracts, or whatever else. We are in a situation that's possibly not happened in the NHS since it was instituted in 1948. And the wait for cataract surgery, given that the surgery takes somewhere between 6 and 10 minutes, is lamentable. It's really sad.
Now, I'm starting to envisage what innovations might address that challenge. You've clearly set out how big it is. I presume training up more eye surgeons is not going to cut it, so to speak.
There's a famous Chinese saying, which I'm sure you know, the best time to plant a tree is 20 years ago, the second best time is now. And the problem with healthcare is that planning clearly leads by a decade or so. It is always hostage to estimates. And I think we've discovered now that there are far fewer ophthalmologists than we need. Worldwide, there was a research study published a couple of years ago which reckoned there are 200,000 ophthalmologists in the entire globe, and that is roughly half of what the planet needs. And clearly, we've got an embarrassment of riches in the UK. We're discussing problems in Scotland, and there are countries in the world where there might be one ophthalmologist per million population, or less even than that. But I'm clearly speaking out of my context, which is Scotland, and we've had 2 or 3 retirements in our department and have really struggled to replace them. So there are not people knocking on the door for posts. It's very much an employee's market. We are struggling with surgeons, yes.
So just before we get to what you're doing then, we're talking about innovation, so I'm just going to try this. Is there any other solution other than surgery? So, for example, with a lot of healthcare issues, we'd be saying, is there a drug treatment?
Thank you for raising that, because downstream of the answer to that question, everything is wrong if the answer is there are other ways to fix it. So let's be explicit. Can you prevent it? Can you treat it medically? By medically, I mean with tablets or some other kind of non-surgical intervention. There is no third option. The option we currently have is surgery. It is fair to say that, not for want of trying, the answer is no. There's no other way of preventing cataracts. People who live very comfortable lives, by which I mean us in the West compared to African farmers, who are not subject to episodic dehydration, working out in the midday heat, will get cataracts much later in life. So undoubtedly there's some causality there. It's far too simplistic to say it's the UV light in Africa and Asia. It's much more likely, I think, to be some of these sort of physiological stresses to the body of poverty, really. But in the West, apart from delaying it, there is no medical treatment. It can't be dissolved by eye drops or by a particular wavelength of light shone in through the pupil. And as I say, not for want of trying. So the surgery solution is the only solution for all intents and purposes.
And you're working in the NHS. The other sort of obvious solution to ask about is private cataract surgery. Can they plug the gap in some way, or is it the same surgeons and therefore the same gap?
The British situation, as you'll be aware, is a hybrid one in that we have both private and public economies and systems running in parallel. I don't think the private system is likely to be the solution, for the simple reason that the vast majority of people are neither insured nor able to afford it. So I think it's just a sheer economics and logistics problem, really. Getting everyone to get them privately is unlikely to be the solution.
You've talked about some of the reasons, for good or ill, that the NHS is resistant to change. How would you go about it for the wider system?
What we've tried to do is to try and show slightly disruptively what is possible, in the hope that others will observe it, like it, and emulate it. So we don't wait till everyone changes till we change. We change something and see if others might like to try it. What I said to my team was, I just want to build a virtual hospital within a hospital. I want to see on 1 day a week what is possible. So let's explore the art of the possible. If I had said, this is the new normal, I think that might have been possible, but I think it might have been threatening. So returning to your question, how do we try and roll this out across Scotland or other places in the UK? I think that's the kind of stage we're at. We're trusting that people will want to emulate it. So there are visitors coming to watch what we do, and it's far better to do that than for me to attend a conference and speak about it.
Is it safe?
The surgeon doesn't feel that they're operating fast, they just feel they're operating well. And we have two massive bodies of data. The first is the National Ophthalmic Data Set, south of the border, and a funnel plot of surgeons' numbers plotted against complications shows without any shadow of a doubt, within the 99% confidence intervals, that the more a surgeon does per annum, the fewer the complications they have. And the second illustrative body of data comes from a study in Canada of 240 surgeons. The surgeons who did less than 250, more than 500, more than 1,000, each of the quartiles had exactly half the complication rate of those who did less surgery. In case I've not explained that well, the more people did, the fewer the complications they had. And that is proven again and again. So that in order to accelerate patients through the theatre in Dundee's model, we do not require the surgeon to move any faster. In fact, everything else gets the patient to the table and from the table precisely so that the surgical moment is unpressured.
If we think 5 or 10 years ahead, what's different?
In cataract surgery, there are three ways to solve the problem. Number one is for all surgeons to do a little bit more. When I said to you that the average was between 4 and 7, the data that we have pre-2020 was that there were 5,500 theatre lists done in that year, in which those were the numbers. And the question is, could we get at least one, if not two more per surgeon per list? And the maths are very easy because 5,500 is very easy to multiply. If two more cases were done on every single list, that's 11,000 surgeries more per year. And the numbers are within traction. What I mean is that in 2020, Scotland should have done 43,000, and by 2030 needs to do 44,000. That's an increase of 11,000. So that's one way to solve the problem. But to quote the Alcoholics Anonymous slogan, if you always do what you've always done, you'll always get what you've always got. And what puzzles me is, why are we not getting bigger numbers in the routine lists? Because every surgeon, it's fair to say, goes to work to do a good day's work. They don't go to work to do a bad day's work. So number one, increase the routine list. Number two, high volume surgery, the kind that we've been experimenting with in Dundee. I am doing high volume surgery and trying to spread the word, but I would prophetically say that that is not going to change the world. I actually think it's the least important of three measures. So getting everyone to do a bit more, I think, is much more sustainable. I think what will happen in reality is that there will be high volume centres. Some people will do it, but not all surgeons will either be capable or will want to do it. And the third way is task shifting. Remember, we said at the start that there aren't enough ophthalmologists. We've recently seen the publication of a manpower study of Scotland's workforce in ophthalmology and optometry. And whilst ophthalmology is really struggling, something like 50% of the optometry workforce are under the age of 40. So it's a very young population. And I think some of the professions allied to medicine may well be able to move into this space. Cataract surgery has achieved 98% success. And Professor David MacLeod, who trained me in my fellowship in Manchester, said 20 years ago that when an operation has become that successful, it's time for doctors to pass it on to other professions. And his rationale was that the reason doctors are paid large salaries is that they are paid to deal with uncertainty. When an operation is almost mechanically predictable, it is no longer uncertain, and it's time to do the decent thing, pass that on to others, because you and I as doctors are paid, said he, to think about things that are difficult, to make the difficult diagnosis and so on. And I think that's prescient. I think that's probably where we stand. I think the collapsing workforce is going to make that a necessity, and I think it's a place that we should move into, embracing it rather than being threatened by it.
You said earlier you were going to make a comment on the profession as a whole beyond cataract surgery. How would you see the future of your profession?
The profession as a whole has a lot more to do than cataracts, clearly, and the specialisms have been subdivided. Pediatric ophthalmology, for example, dealing with retinopathy of prematurity in premature babies, and pediatrics such as squint surgery and glasses and congenital conditions. And I could go on with examples. All of that is where the doctor working to the top of their license should take that learning and that expertise, I think. So the rest of the profession could be enhanced by having the professionals moving into those proper areas and away from the more straightforward cataract surgery aspect of things.